You're on air. Dr. Shikha?
Yeah. Good evening, everyone. I am Dr. Shikha Verma, Medical Advisor for Lupin Oncology. Lupin is an innovation-led transnational pharmaceutical company and is one among top 5 Indian pharma companies. And we pride in belonging to an industry which makes a difference in lives of the people. On behalf of Lupin, I welcome you all for today's session. And the topic for session is Grand Rounds in GI Oncology. For further proceedings, I would like to welcome our Program Director for the session, Dr. K. Govind Babu, Senior Consultant Medical Oncologist at CG Bangalore Institute of Oncology. Over to you, sir.
Thank you, Dr. Shikha. It's nice that Lupin has organized this and got us all together. So I think without further ado, let's get started. The first one is by Dr. Advait Gore. So Advait, I think you can get it started.
Yeah, sir, unmute yourself. Advait, sir.
Is my screen visible, sir?
Yes, sir.
Yeah, okay. So we go ahead. I'm going to be discussing a case of using for systemic therapy in left-sided metastatic colorectal cancer. And our essential discussion would be on the role of various options which are available. So we know that treating metastatic colorectal cancer is like treating more than one disease. At a molecular level, it is different. There are multiple other biomarkers like HER2, BRAF, wild-type mutant, RAS wild-type mutant, then the anatomical location, whether it is left-sided, right-sided, rectal, in younger age group versus elderly age group, and also based on the stool flora types that the disease may change and present in different ways. But when dealing with a metastatic colorectal cancer, there can be three different strategical approaches that we can follow, looking at easily resectable, potentially resectable disease having stage 4, and patients with never resectable disease. And with the current treatment paradigms, we know that patients with limited stage 4 disease can be cured with an interdisciplinary approach. The addition of biological agents to chemo has also improved outcomes, but identification of molecular predictive factors is also important. So with so many different agents at our disposal, the dilemma is how do you plan therapy and how do one go about sequencing the treatment in such patients. So coming to the case discussion, now we have a 58-year-old woman who's a teacher, married, enjoys hiking, and she presented to us with history of constipation and weight loss. Weight loss was significant, but there was no other symptom associated. Clinically had EPOC PA 0. Clinical examination did not reveal any positive findings. Colonoscopy biopsy was done because stool showed that there was blood in stool, microscopy, and the biopsy revealed that there was an adenocarcinoma in descending colon. Lab tests were other lab tests like CBC biochemistry were normal. She doesn't have any comorbid medical illness, and the CEA is 68. CT scan of the abdomen pelvis done showed that there was no distant metastasis, and this lady had a left-sided colon disease. So she underwent an initial surgery with a left-sided hemicolectomy, pathologically reported as PT3N1 grade 3 tumor with 3 out of 15 lymph nodes positive, and a post-operative CEA of 15. She was counseled by a medical oncologist and a surgeon to receive adjuvant chemotherapy, but refused because of toxicity concerns of neuropathy, which may remain long-term due to oxaliplatin. She opted to be in observation, and at 6 months follow-up visit, CT scan shows that there were nodes and there were some peritoneal disease. So we have a lymphatic relapse and a peritoneal surface relapse. Patient is asymptomatic. CEA done now was 266, and the pathology of the primary tumor was grade 3 adeno-CA at diagnosis. So my question to our panelists, what influences the treatment choice in metastatic colorectal cancer? How do you take a decision regarding that? Dr. Biswas or Dr. Bharat, if he is joined?
Yeah, we are.
Yeah, Bharat.
So basically,
the factors which influence treatment of metastatic colorectal cancer is basically how fit is the patient. First, most important thing is the fitness of the patient is important, like whether the patient is fit or unfit. Then start the biology, aggressiveness of the disease, and as you have mentioned in your first slide, that there are various factors, that anatomical factors, molecular factors, and the disease burden. These are the factors which decide. So you are looking at a young, fit lady who refused adjuvant treatment, and she ended up in extensive disease in the peritoneum, which looks like peritoneal disease is palliative for me. So
Yes. I think even lymph node disease would be palliative for most of our patients.
and the further workup then based on what molecular characteristics she is showing, as you have mentioned everything in the file. Nowadays, I would like to go for an NGS based, including the.
Okay, yeah, we are coming to that. So we are coming to that.
Yeah, Advait, only sad thing
Yes, sir.
for this lady is, she would have benefited with adjuvant therapy, so that is a sad
Yes,
part.
sir.
It's a loss of opportunity for her,
Yes,
really sad.
yes.
Yeah, so I don't know how we can push such people to really take adjuvant.
Take adjuvant therapy.
Yeah. Okay, thanks.
So, so we actually before decision making, I thought of these points for molecular markers as to what is undoubtedly needed before decision making, and this is actually for benefit of students here.
Advait,
Yeah, Bharat.
yeah, before coming to the further workup, when she refused for the adjuvant chemotherapy, and
Yeah.
she is into hiking, or she was into hiking, she must have refused because of the oxaliplatin, related
Yes.
neuropathy. So
Yes, yes.
we should counsel such patients for at least 5FU based or capecitabine or oral tegafur based therapy, because there is a data for 70 plus patients that oxaliplatin adds little to the 5FU. Basic backbone is basically the 5FU leucovorin.
Yes.
So you have some oral drugs which can be given without lesser toxicity. So
Yeah, and even with the IDEA study, you can do with only 3 months of K-pop in
Correct.
such situations which are low risk, the stage 3
Correct.
also.
Correct.
So if this lady has only 3 nodes and she's T3N1, she fits into the category of IDEA study of low risk stage 3.
definitely 3 months course is ideal for her.
Yeah.
And the risk of neuropathy would be the least with 3 months of K-pop
Correct.
rather than giving 6 months of K-pops or 6 months of Folfox also. So this is a discussion on basically what markers do we ask for before we actually decide whether we look at RAS status only, whether we look at expanded RAS, whether you look at RAS, BRAF, look at RAS, BRAF and MSS status, and whether all of that information is actually less relevant than the PET CT scan, which already shows that there is disease. Any idea about this? What one would do? Dr. Biswas, Bharat, Ankur, if he is here.
Dr. Ghanshyam Biswas is having some trouble in audio, sir.
Okay.
Yes, audio.
Okay.
So
Yeah. So, yeah. Bharat, can you take this?
yeah, so I started answering the thing,
Yeah.
So I answered, I think, first part. Next, and second thing is nowadays, I prefer doing, everything together, like,
Yeah.
just including the markers for immunotherapy.
Okay.
Which I think, your slide shows all the markers.
Yeah. So
Yeah.
what platform do you ask them to do? Do you ask for an NGS or do you ask them one after the other? Because many a times patient and us as treating doctors also we face a dilemma as
Yes.
to whether we ask everything at one go and wait for the information for 3 weeks or whether just ask for all RAS, BRAF and MSI and then take a decision whether you need to do additional.
So I think the colon is also evolving as lung cancer. Previously in lung cancer we used to order 4 markers, and then we slowly started expanding. And now I think I think everybody should agree that today is the era of NGS. You order it, but there are certain cases where you want the result faster. The problem with the NGS, it takes time, right? But that's okay with the colon. I think we should not be in that hurry as in the case of
As
lung.
in lung.
Yeah, that's
It's
right.
very-
Advait, now is this lady convinced for taking chemotherapy?
Yes, she is convinced for taking chemo.
Okay.
She's realized her mistake that she should have taken it before.
That is sad.
corporate ladies, sometimes of such. And I had some few cases.
Yeah.
Very highly educated, their
Yeah.
level is sometimes above us, but in case of taking
Correct.
they make this mistake, and unfortunately, by the time they realize,
Yeah.
it's all palliation.
That's true.
Yeah.
Advait, I agree with Bharat asking for an NGS upfront for all the markers, and waiting for these, I would start with like Folfox and bevacizumab,
Okay.
for which you don't need any of these things.
Absolutely. I completely agree with you, sir.
Yeah.
The issue comes up here because this is a left-sided deep primary, and then there are metastases where naturally the decision whether to offer a EGFR antibody is also high up on the card.
Correct.
But I think, sir, that decision mainly depends, and whatever the data has been there in anti-EGFR, it is mainly for those patients who have liver-limited disease in whom you want to do a potential liver resection.
Correct.
And not that much for patients with peritoneal disease or lymph node disease. In fact,
that's right.
Patients in these two categories were the ones who did not do that well with the anti-EGFR inhibitor.
Correct.
So, coming to that, the next part of the discussion was on whether RAS and BRAF mutants are different from double wild type. And obviously they are, because they carry a different prognosis and they also have a different response to treatment. And we've known this right from the 2017 JNCI publication of the PTAC-8 study, which has shown that the BRAF mutants are really the ones which are doing very poor. The KRAS mutants are somewhere in between, and the double wild type are the ones which do the best. So this lady's molecular profiling then came in, showed that it was a wild type ALRAS, wild type BRAF, MSI stable, and HER2 negative. As Bharat has said, we did an extended panel of testing and we got these reports. So mainly the questions that then come up here is, what should be the choice of first-line therapy, whether we look at an escalation or a de-escalation approach in terms of operability. There is a lot of data coming in for salvage cytoreductive surgery and HIPEC for patients with limited peritoneal disease in such situations with metastatic colorectal cancer. The choice of targeted treatment, there are certain treatment strategy-related questions in which whether we would give maintenance or give a stopgap, whether we go ahead with treatment beyond progression, and naturally there is a question of local regional treatment in terms of what would be the role of surgery. I think now we would come to the question regarding the first line therapy as to the choice, and Govind Babu sir has already given his preference. I would request the others to give their comments. Sir mentioned about using combination chemo with bevacizumab even without waiting for the NGS report to come in. So, Bharat, can you take this up?
Yeah, I agree with
Dr.
my choice also. For sometime it is like comfortability with the bevacizumab. Now, whether the triplet or doublet, before that, I would like to take this case to for a discussion where I would like to discuss with the peritoneal surgeon. And that upfront we have to take a call whether this patient is going to come for surgery in the future, even if it is unresectable. That is an important point after the fitness of the patient. That decides what doublet or triplet. If it decides as a palliation, then I would not go for triplet. I would go for doublet with bevacizumab. The most important point from your graph that double wild type are the best. Why is it important? You have at least that option in the future or now using panitumumab, sequentially with the VH. That is why doing upfront or
Absolutely, you really made the point very clear. Ganesh, I see you have joined us. Ganesh is a dear friend and a GI hepatobiliary surgeon of Hinduja. Ganesh, your comments on this, whether you would be a part of the multidisciplinary team deciding on whether this patient would come in for surgery at some point of time.
So this patient has peritoneal recurrence that just mentioned. If he has not seen
peritoneal, so this patient essentially has not received adjuvant chemo. She is a stage 3 low-risk disease who refused adjuvant chemo, and 6 months down the line had peritoneal disease and lymph node metastasis. I think Ganesh is appearing frozen. We'll come back to that.
Yeah, Ganesh, please unmute yourself. So Dr. Vishwas has joined.
Can
You can switch off the video, then you will know.
Yeah, then you may.
You switch off the video.
Correct.
yeah. Can you hear me now?
Yeah, it's better now.
Yeah, Ganesh, I can hear you.
Yeah. Can you just come back, Advait? I had some issues with my network, so
Yeah.
I think things are better now. Can you just?
Yeah, I'll just summarize the case for you. She is a 58-year-old lady who was diagnosed with left-sided descending colon grade 3 T3N1 disease. Underwent a colectomy, and then because of risk of toxicity, maybe neuropathy, she refused because she's an avid hiker, a trekker, a teacher by profession, and did not want to experience the neuropathy, so refused the adjuvant chemo. And after 6 months of initial surgery, now has an increase in her CEA and has peritoneal disease and lymph node metastasis. And she is all RAS wild type, BRAF wild type, MSI stable, HER2 negative. Yeah, so we were discussing regarding what would be the approach of surgeon towards this, whether she would be a candidate for cytoreductive surgery plus minus HIPEC at some point of time. Yeah, hello. If she would be a candidate for any surgical procedure at some point of time, so as to decide our systemic therapy based on it.
Yeah, somebody has asked what is PCI. So let us make it very simple that patient has limited peritoneal disease.
Yeah, limited peritoneal disease.
Correct.
I think he is not.
Okay.
Something.
I think we'll move on, sir.
We'll ask him the same question when he joins.
Yeah, we'll ask him later.
Yeah,
So
I think this is Advait, I think this is the importance of a multidisciplinary.
Yes, sir.
Each one looking at it from his or own perspective,
Yes.
The patient will not get the best. So now actually I'm reminded of one beautiful slide which Dr. Ian Smith from UK had put up. His slide said if a patient goes to a radiotherapist, he'll get radiation. If a patient goes to surgeon, he'll get surgery. If he comes to medical oncologist, he'll get chemotherapy. If you go to a barber, you will get a haircut. So I think that actually summarizes what a multidisciplinary team is required for such cases.
Yes.
Yeah, go ahead.
So there was a lot of discussion regarding what should be the backbone of chemotherapy along with these targeted agents. And there was this study published way back in 2004, which showed that whether we use Folfox or whether we use Folfiri as the initial line of treatment, the outcome is not really much difference between both the groups. Of course, giving Folfox and then Folfiri was slightly better at a median follow-up of almost 1.5 years. Coming to triplet, as we have mentioned about Folfoxiri versus Folfiri, triplet chemotherapy, whether it is the best choice, yes, it does appear to be more beneficial in terms of responses, but the toxicity is quite significant, and you really need to have to pick your patient to actually tolerate this kind of regimen. For me personally, I use this in patients who are less than 50 years of age, no comorbidities and good cardiac and hepatic function, possibly with a liver metastasis which is limited, and these patients cannot go for targeted treatment, or I use this combination in patients who are right-sided disease with BRAF positive, in which this regimen is the treatment of choice. So, Ganesh, if you have connected, can you please discuss about the role of surgery in metastatic colorectal cancer?
You must be
He hasn't joined yet, sir.
Yeah.
You must be operating on your patient.
So Dr. Ankur is there, sir.
Yeah, Ankur is also here. Hi, Ankur. Welcome. So we know that surgery for a metastatic disease, if there is resection of metastasis within the first year of treatment, there is definitely an improvement in survival, and there definitely is a greater benefit if the complete surgery can be done within 4 months of starting the treatment. Now, in RAS wild type tumors, we know that there are multiple choices in terms of cetuximab, panitumumab, and Bev, and the chemotherapy backbones also differ. So we have a study called Olivia study which looks at unresectable colorectal cancer with mets only to the liver, where patients have been treated with Folfox Bev versus Folfiri Bev, and the patient PET was actually done to exclude extrahepatic disease, and they showed that Folfoxiri with Bev, the 4-drug regimen, did better in terms of response rate and R0 resections for the liver. There is also a similar study using modified Folfox 6 Bev versus Folfiri Bev, and Folfiri did slightly better than Folfox. In RAS wild type microsatellite stable disease, does the anatomical side matter is a question. Now, Bharat, Ankur, if you want to discuss about this,
Yes, of
I
course.
would invite your comments on this.
Yeah. So anatomical site matters, yes, and I will be discussing the same in my discussion. So left and right, so right-sided colorectal cancers, when we have wild type status, so the data, the meta-analysis, the CalGB study clearly says that the bevacizumab has an edge, and when we go on to the left side, we have either way. We have either way to choose cetuximab or bevacizumab, but in right side, the literature and the data clearly says that it's bevacizumab which has an edge in the survival benefit. However, at point when the tumor is borderline resectable and when you are giving it in a neoadjuvant setting, so we usually imaging and we do evaluate these patients after 2 months of therapy, which is 4 cycles with or without bevacizumab. However, when I think there's a problem with my video. However, when when I have to give first time chemotherapy, I will start with Folfox. The bevacizumab will be added time depending upon the EGFR status. So I won't be able to give more than 2 to 3 cycles of neoadjuvant bevacizumab, and then I have to do a liver resected surgery or a main CRC surgery. So in that case, Folfoxiri will be one of the options where we can even omit bevacizumab.
Yeah, I completely agree with this. I think this is the data from the FIRE 3, and I'm sure you will cover this in your talk, so we'll just skip through this, and the CalGB study which you mentioned. And in RAS mutated tumors, we really don't have a choice of targeted treatment, and Bev is the only one that we can use. And this has been really underlined by the TRIBE group of trials. This was the initial TRIBE study which showed that there was significant improvement in efficacy by FOLFIRINOX and Bev. And then the TRIBE 2 also looked at further improvement, randomizing first line, second line treatment with Folfoxiri versus sequential Folfox Bev and Folfiri Bev. And this really showed that there was improvement in terms of overall response rate and PFS. So this patient actually started on chemo with Bev and Folfox, and then after 2 months CEA had decreased, and 6 months patient did have some CTC grade 2 asthenia. Patient was wanted to avoid symptomatic toxicity, so we were looking at doing an evaluation. And at 6 months, the follow-up CT scan showed that there was a minor response, stable disease according to RECIST, no tumor-related symptoms, there was mild neuropathy, and CEA had come down. So what would be the preferred management here in this situation out of all? Whether we stop treatment, then until progression, then treat, continue with Bev alone, continue with a fluoropyrimidine, either 5-FU or capecitabine, or a combination of fluoropyrimidine plus Bev, or continue with Folfiri. Anyone, Bharat, Ankur, Dr. Ghanshyam Biswas, Sohan Babu sir.
So I think the data of maintenance therapy. So when we talk about maintenance therapy in CA colon, it is always the bevacizumab with either a capecitabine or a fluoropyrimidine derivative.
Absolutely.
And there is a study of in VEGF inhibitor. Yes, this is the CAIRO 3 study.
The CAIRO 3 study. Yeah.
Bevacizumab versus observation alone. So we have been using bevacizumab alone or cetuximab alone in our practice, but the literature always says that we have to either combine with 5-FU or capecitabine. Same as the data with panitumumab, which is the Valentino study. So combination maintenance therapy is the rule whenever we have to do it.
Absolutely. So wherever possible, dual maintenance using a fluoropyrimidine backbone and bevacizumab is what is followed, and the same was used that this patient initially looked at Folfox Bev, then Cape Bev, and then suddenly vanished, went trekking in Ladakh, and then came back within 4 weeks with CA increased and nodes have also increased. So in such situations, what do you do if there is a disease progression within a month to 6 weeks of stopping treatment? We know that suddenly stopping bevacizumab does lead to a flare-like reaction. And do we wait till she becomes symptomatic? We restart with oxaliplatin-based therapy, give her FOLFIRI with anti-EGFR or BEV or aflibercept.
What was the amount of disease? What was the amount of disease?
The lymph nodes have increased. She is not symptomatic. Her performance status still remains 0 and CE has gone high.
Yeah, we can wait for some time. We may be following up every 6 weeks and see. And once he becomes symptomatic, because he is not exposed to anti-EGFR, so here we'll change the backbone of chemotherapy and the backbone of targeted therapy both.
Okay. So these were certain factors which I came across in the review of the literature, that as choosing second line treatment, yes, we need to consider what the prior treatment has been with EGFR or VEGF inhibitor. If there is progression within 6 months on prior VEGF inhibitor, or if then there is a possibility of re-challenging the same. If the patient has received prior VEGF and more than 3 months of maintenance, then there is also a possibility of changing to aflibercept or in place of bevacizumab, and we really are lost for options in this situation.
Yeah, in this particular patient was on maintenance.
Yeah.
Such patient, now this is now defaulted patient, but it is better. The advantage of bevacizumab capacity of maintenance and changing the chemotherapy arm, you can clearly see the continuation of bevacizumab definitely translate into PFS2.
Yes.
So when the patient shows rising CEA and though patient is asymptomatic, this particular patient, knowing the fact patient has a tendency to default again and again, obviously will definitely consider surveillance in particular patients who are ready to come for immediate
on a regular follow-up.
Yeah. Such patient I may not wait.
Absolutely. So as I said, there are scenarios in which you use cytotoxic doublet with BEV. You can use a cytotoxic doublet, use BEV beyond progression or change to anti-EGFR antibody, or you can use an EGFR in first line and use BEV as second line. Third line would be again an anti-VEGF with regorafenib. So essentially, if you are using BEV in first and second line, you can reserve your anti-EGFR antibody for the third line setting, and regorafenib then goes to fourth line. So you are exposing patients to more amounts of drugs, and naturally there is a proportional impact on the overall survival. As the number of lines of therapy improve, the patient's overall survival also increases. So it is imperative that most of the patients should be exposed to all active and approved agents during the treatment, and with proper monitoring of the disease and also managing the toxicity. So the key points out of this is, yes, the duration of VEGF inhibition does matter. Treatment to progression should be the strategy in stage 4 disease. There are certain maintenance strategies which can be used, and there is also an option of treatment beyond progression. We should use the synergism between fluoropyrimidine and bevacizumab in terms of maintenance, and prolonged VEGF inhibition beyond progression has also been supported. And now with the phase 3 TRIBE 2, we can combine it with folfoxiri, also with BEV in right-sided tumors and even in certain left-sided tumors where there are adverse factors, or with liver-limited disease where surgery can be done. I think I'm running out of time, so this is my last slide. Thank you very much.
Thank you. That was a nice case. And you brought out quite a few points that were interesting. I hope this patient is convinced now to continue the therapy. So with that, let's go on to Dr. Ankur Pan. Ankur,
Thank you so much, sir.
I don't need to introduce you because everybody knows you.
Yes. So I'm Ankur, and thank you, Dr. Govind Babu, and thank you, Dr. Advita Gore, Marat Bhosle, Ghanshyam sir, and Dr. Ganesh Nagaranjan. I think these are my panelists, and sorry, I'm not on camera because my camera has a problem. So this is bevacizumab concentrated meeting, and so this next 30 minutes we will just discuss that 80% of the time, 80% of the time you are correct if you are using bevacizumab, whether it is a left-sided tumor. So straight away with this slide, 80% chance that you will be using bevacizumab in your practice, and I would be straight away asking Dr. Ghanshyam Biswas, in view of the generic bevacizumab, in view of the cetuximab and panitumab is too costly. So what is your say? How comfortable are you using upfront? I would without testing KRAS and RAS on a left-hand side tumor to start with bevacizumab and your favorite Folfox or FOLFIRI-based chemotherapy in a metastatic colorectal cancer.
Yeah, Dr. Ankur, so you are correct. So most of the time you'll be right if you are using bevacizumab as the backbone of targeted therapy and whatever chemotherapy. So you will have only 20% chance, and that too only on the left side if you're talking about the first line therapy where you have scope for anti-EGFR. So whether you choose cetuximab or panitumab, we know that they are interchangeable, though we know that the for scientific data of cetuximab is more. So we are very
30 minutes we'll be discussing what is this 80-20 figure and how we actually get it. And as Dr. Advita also said that how to use bevacizumab, even if you have used it bevacizumab first line, can we use it on your progression? That was a TRIBE2 data. And what next is that FOLFIRINOX with bevacizumab in a fit patient, we can use this 4 drugs regime to get the best response rate and make it resectable if we can. So Dr. Bharat, so what very similar question, you have been asked this question multiple number of times. What factors your treatment choice define in metastatic colorectal cancer?
Actually today's discussion started with this question only. So
yes,
I will repeat again. So basically, first and foremost important factor is the patient, right? Yeah. The fitness of the patient, whether the patient is fit or not. And then comes the secondary points, whether the patient has not many comorbidities or without comorbidities. Then comes the tumor factors, like we do molecular characteristic, and we have discussed, nowadays we order NGS. We have all the information, and then you can choose the treatment. Backbone of the therapy is definitely 5-FU-leucovorin has to be there, either IV or the oral formulations, capecitabine or leucovorin or whatever, because that is the available alternative in the country. And then we choose based on the anatomical location, right or left, if it is dual wild type of disease. So these are the factors we take into account.
So as Dr. Govind Babu says, even going to barber is not easy. Barber will also ask you further questions, how well cutting you want, short, long, design, not to me but rest of you. So it's patient characteristic, it's tumor characteristics, is the location of the tumor, is the most important which is coming is the molecular characteristic and continuing molecular characteristic. There are plenty of studies coming which says that the circulating tumor cells recheck the KRAS, NRAS status, the NEO-RAS study, of course the patient preference, the quality of life and the toxicity profile, and most important the financial toxicity which my patient will be able to bear with this anti-EGFR or anti-VEGF of the world. So the therapy has to be tailored according to the patient needs and of course according to the science which is required.
So,
yeah,
so financial toxicity is going to increase with the MSI positivity coming high.
Yes. And in our post-COVID era as well.
Yeah, so everything else is cheaper now.
Yes. So molecular characteristics we have now stable. We have MSI high. Another amplification which is HER2, BRAF mutant versus mutant, and RAS wild type versus mutant, and anatomically right and left, and certainly the performance status of the patient. Previously, Dr. Gore has already talked that left and right-sided tumor are totally different. So just a brief, Dr. Ganesh, if you are there, can you just brief me about the overall survival of these left-sided and right-sided patients, Ganesh? And if not, then Dr. Ganesh, Dr. Gore can comment on that. Dr. Advait.
So we know that Ganesh, I think, is really not coming online. So I think the left and the right-sided disease are embryologically completely different. And even when we look at a situation wherein we are treating these patients in the adjuvant setting as compared to the metastatic setting, there is difference in outcomes between these patients. In the adjuvant setting, the right-sided disease has better prognosis than the left-sided. But when we reach the metastatic setting, the left-sided disease has a better prognosis. This essentially has multiple aspects to why this happens. Is basically it is also related to a higher incidence of mutations in the right-sided disease, which make this an inherently aggressive disease, where the signaling of the tumor is activated and there is KRAS mutation, there is BRAF mutation, and the extent is that if there is a BRAF which is seen in about 60% patients with right-sided disease, it's seen in only 4% in left-sided disease.
Yeah.
Right? There is also MSI high status in the right-sided, which really makes these inherently resistant to chemotherapy. And that's the reason why we are seeing data of triplet chemotherapy, where you need to use an aggressive regimen using the best drugs possible to get a response in these groups.
So very, very rightly said that left side, right side, adjuvant setting or a metastatic setting, and MSI, BRAF, KRAS mutancy, even HER2 positivity, they left side and right side. So asking this question to Dr. Govind Babu sir, I would say in last 3 decades of your practice, what has changed in CRC? So you must have seen those 5FU and leucovorin era. You have seen this targeted era, and now we are moving on to the immunotherapy era, and particularly the surgeries, the RFAs, the TACE which have been doing. So how, sir, how have you seen this huge paradigm shift and giving this output to your patients? Dr. Govind Babu sir.
Yeah. When actually I started my oncology practice, we had leucovorin and 5FU, that's all.
Yeah.
For any patient with colorectal cancer. So from there we have come a long way. And the typical slide that anybody shows in a colon cancer treatment is how we have progressed in terms of survival over time because of better chemotherapy drugs. And yes, that is the slide I was talking about. So it shows how we have progressed over time from using just 5FU leucovorin, then came in our oxaliplatin, then irinotecan, and the biologics. And to that, actually, what's helped us is our understanding of the molecular biology of the tumor. And we know that it's so important that you look at all these molecular characteristics, because that is when you can hit your therapy very well. And you were talking about left-sided, right-sided colon cancers. Now, actually, there is data to say that the rectal cancer is not the same as left-sided colon cancer, because there are distinct molecular signatures that are different. So that is how we have understood colon cancer today. And because of all this, we are now able to see that their survival from just a few months is going well beyond 24 months. So that is a great difference that I've seen in the last 3 decades.
Yeah, even the panitumumab study, the PEAK study, which says the survival up to 45-50 months. And over in last 3 decades, the amount of surgery which has been happening in colorectal cancer, the amount of high-tech surgeries, radio frequency ablation, we have been using SBRT to unresectable liver, and we have used especially TACE also in those liver-studded tumors which have helped, and certainly adding of biologicals to the chemotherapy, as Dr. Govind Babu said, cetuximab, panitumumab, Avastin, progression beyond progression, TRIBE1, TRIBE2. So these are the all measurements to increase the output. And the third point is that identification of predictive factors. Between this circulating tumor DNA cells in colorectal cancer, where we actually see the RAS status, whether it has been retained or it has been mutated. So where the cetuximab and panitumumab can be reused or not used according to the molecular factors. And certainly the immunotherapy is coming our way, especially in high colorectal, and this year ASCO update that we can use immunotherapy upfront in these colorectal cancer. And what I have seen in my 1 decade of practice is that these generics and low cost of such drugs, bevacizumab was seen as luxury, and one of our non-Delhi medical oncologists used to say that bevacizumab makes beva, Beva means a widow. So it used to extract money. Now it's available at certain cost where many people, and we have been more using this bevacizumab because of generics and the low cost. So these are the factors which have increased our patients' survivals and our own experience with this biological agent. So as Dr. Govind Babu said, that now we have a luxury, but this luxury at times becomes disadvantage. So we have to choose and pick up these blocks, and we have to fit in patient XYZ who will fit with bevacizumab, who will fit with cetuximab, panitumab, who will require again re-challenge of these drugs and so forth onwards. So this is the evolution which Dr. Govind Babu was describing, that this is ever changing, and we will have certainly more number of graphs to start with. So as Dr. Gore was also mentioning, so we have two signaling pathways, EGFR, VEGFR. We have to choose one of them in the left side, or in the right side. Bevacizumab has a advantage. So as all my panelists agree, I would take this question myself. Yes, we consider sidedness for treatment selection in first-line colorectal cancer, and as Dr. Ghanshyam said, we at times use bevacizumab as a blanket biological, irrespective of the RAS status, if we feel that the patient may or may not able to bear the cetuximab course and he does not have any contraindication to bevacizumab. So I'm coming on to this simple case which was operated in 2019, a sigmoid colon, which is a left-sided colon, and it took adjuvant Capox with grade 1 neuropathy, and CEA became normal, and then it finished in August 2019, and in January this patient had abdominal pain, weight loss, multiple liver metastasis, retroperitoneal lymph nodes, and lung metastasis as well. And on molecular analysis, the primary analysis was that KRAS, NRAS was wild type, BRAF was wild type, and it was microsatellite stable. And our fellow colleague in surgical oncology has termed it it's unresectable in view of multiple liver involvement and the lung involvement. And the patient straight away comes to the initial medical oncologist. And so Dr. Ghanshyam, left-sided colon cancer, BRAF wild type, KRAS, NRAS wild type. Oh, what is your choice in left-sided colon cancer? This is not right-sided, left-sided, sir. Dr. Ghanshyam.
Yeah, so these will be the few patients where if money is not a constraint, so I will definitely take for chemotherapy with an anti-EGFR.
Okay. Any takers for bevacizumab or any takers for triplet with bevacizumab? Dr. Bharat Bhosle and Dr. Gore and Dr. Govind Babu, sir.
Yeah, so basically, what important factor is what is the disease-free interval, what are the residual toxicities?
So it was August 19, we stopped adjuvant chemotherapy, and in January 20, within 5 months, PFS of 5 months, the disease came back.
Yeah, so it itself suggests the aggressive biology of the disease. So, but sometimes we get more disease-free intervals, then it is very important the lung metastasis. If the disease burden in the lung is not great, definitely we have to have a chat with the surgeon friend. In the future, if the patient gets response with the lead drug and bevacizumab or cetuximab, with the availability of alternative ablative measures for smaller lesions, metastatic lesions, like sometimes we use RFA. So definitely assessment of this patient, whichever therapy you use, if the patient is fit, no residual toxicity, I would like to go for 3 drugs, either with bevacizumab and cetuximab. Knowing that the patient doesn't come for surgery.
Ankur,
yes, sir.
So maintenance is important after this, if the patient is not coming for surgery. So I would go for bevacizumab.
Okay, Dr. Govind Babu, sir.
Yeah, I think I agree with what Bharat has told so far. So those are all the factors that we need to keep in mind. And since this recurrence is within 4 months, so it's definitely an aggressive disease. And we should discuss with the patient, and if we can tolerate a triplet with a biologic, I think that is the way I would.
Yeah. Dr.
Ankur,
yes.
Yeah. Ankur, we are dealing with a patient who has a very aggressive biology of disease, and as mentioned, the patient has relapsed within 6 months of receiving the platinum.
Yes.
And I would probably be more in favor of using a doublet chemotherapy with FOLFIRI with BEV, because there has been direct comparison of FOLFIRINOX with BEV and FOLFIRI with BEV, and those patients who have received oxaliplatin before, they did poorly with the triplet chemotherapy and bevacizumab. There was no difference in between them. So my choice of treatment would be to use a doublet chemotherapy and because we are not looking at early response, or we are not looking at bringing a early response in terms of resection, my choice would be to go for bevacizumab for a longer PFS and an overall survival benefit, as I will use the bevacizumab as a maintenance treatment also later on. Which doing maintenance with EGFR is a bit difficult.
Yeah, so rightly said by Dr. Gore, and I would not also disregard Dr. Ghanshyam Biswas. So Dr. Gore said that those patients who have failed, I would say this patient has failed adjuvant therapy and within 4 or 5 months platinum resistant or failed oxaliplatin. The data says that anti-EGFR won't work, but I would not disregard Dr. Ghanshyam Biswas. He wants to use Volfiri with cetuximab, and that is also one of the options. So house is divided, both are right answers, but yes, we have to choose and take this patient as a poor prognosis. Had it been a right-sided colon cancer, then I would jump on the answer to say that sideness matter, and since this patient is not a surgical candidate and patient has received platinum oxaliplatin with 5-FU 4 months back, so either a bevacizumab with single agent irinotecan or a Volfiri with bevacizumab would have been certainly my choice in a right-sided had it been a wild type or a MSS stable.
Yeah, so Ankur.
Yes, please. Yes.
Ankur, if this is not the case for an anti-EGFR, then which is the case for an anti-EGFR? So we are talking about a first-line metastatic, and that too on the left-sided. So if you are ruling out anti-EGFR, then there is, I think then, so you telling us 80-20 doesn't make sense, then it is only 100 and 0.
Absolutely. Point is well taken, and Dr. Gore gave that answer that those patients who have progressed within Dr. Advait, can you want to plan that? Yeah.
So those patients who progress within 6 months of oxaliplatin completion are generally not a great candidate. And as I said, my choice of using an anti-VEGF is because I can use bevacizumab as a maintenance, which is much better tolerated than an anti-EGFR as a maintenance. We have tried using panitumumab as a maintenance, and it is.
But Advait, if you look at the depth of response or the tumor shrinkage, the data or the science is more in favor of a cetuximab rather than a bevacizumab.
I agree, sir, but that is in situations where you would want to do liver resection.
Pardon me?
Where there is a potentially resectable patient, I would look at the depth of response. In a patient
I'm talking about symptomatic. So earliest response is not converted. So this patient unlikely to get converted into a surgery. So if this patient is for a surgery, then definitely I will use a triple 4 drugs there.
Yes.
So as you also said that you are using 2 drugs, so we are not thinking that this patient will be a fit for surgery at any point of time. But a depth of response or early shrinkage is not only converting to a surgery, but for a symptom control is also important.
Absolutely, I agree with that. But if you look at the progression-free survival curves of the FIRE3 data, which is directly compared Bev versus cetuximab using the same chemo backbone, the PFS curves in left-sided disease are almost overlapping. It's the overall survival which has made difference, and whatever this left and right was there, what initially came in was a retrospective analysis. It was not a prospective analysis.
So both the panelists have a point, and I agree with both Dr. Advait and Dr. Ghanshyam Biswas that both are the options, but we can use either of them first, and later on, when the patient relapses further, we can use further option which is being left. So that was the NCCN also tells us. So again, coming on to one more type of colon cancer, which is BRAF mutant, and any experience, Dr. Bharat and Dr. Advait Gore. So whenever your patient has BRAF mutant, what is your experience with anti-EGFR or anti-VEGF? What do you choose?
Yeah, Ankur, I have an experience. I will share you. So these BRAF mutated are rare patients. No? So, but these patients are actually right-sided tumors. They are elderly and usually they are frail. So if you look at the BRAF data, so triplet drug, bevacizumab. But in real life, if you see, so these patients may not be fit for an aggressive therapy, though they warrant an aggressive therapy. So I had a gentleman of 72 years, right-sided BRAF mutated. So I started on Folfox, and once the mutations were available, I shifted him to Folfox plus bevacizumab. So post 3 cycles, absolutely, there was so poor tolerance, and subsequently he discontinued therapy and died.
Absolutely, and and so does the PRIME study and the COIN study also say that patient who have a BRAF mutant, so panitumumab and cetuximab actually did not give that advantage in those who are BRAF wild. So these are the studies in which yes. So again coming on to this graph which was saying that wild type is 50% and mutants are 45%. If I add BRAF mutation which is another 5%, so 50% of my patients are eligible for bevacizumab or anti-EGFR therapy. So when it comes to the head-on-head trial, which was a FIRE trial or a CalGB trial, which actually studied bevacizumab and cetuximab one-to-one random fashion. So it was clearly that in FIRE 3, the OS was in advantage to cetuximab, but there were like criticism to FIRE 3 that it did not meet the primary endpoint. PFS was identical with respective of cetuximab or bevacizumab. There was a lack of third party, late divergence, and low rate of second line therapy in the bevacizumab. So there was a criticism which was published in JCO 2015 when we come to upfront uses of cetuximab and bevacizumab, and this was the comment in NCCN as well, that lack of third party and low rates of second line therapy in bevacizumab group. So cetuximab was not that favorite, which FIRE 3 showed. So this was CalGB, which shows that there was no difference in PFS OS with respect to RAS wild type. So both bevacizumab and cetuximab were actually equal. The graphs are actually kissing each other with 11.3 and 11.4, which was PFS, and overall survival was also 31.2 and 32. So irrespective of the RAS status, if we choose even bevacizumab upfront, that is equivalent to cetuximab even in the wild type. So this was a meta-analysis which also NEGM Journal Watch, which also says that it does not matter whether you use a bevacizumab or cetuximab, and this Dr. Gore told in detail. So coming on to my 80-20 sidedness, that so if my all RAS mutant is 45%, my BRAF is 5%, and my RAS wild type left person is 30%. So I'm left with 70% of the time when I use BRAF state, when I use the bevacizumab, it is right. So it is coming to 70-30. So left-sided tumors are 30% and rest all RAS wild type right side and BRAF mutant patient, my bevacizumab is the choice of therapy. So NCCN 2019 also says that cetuximab and panitumumab confer little, if any, benefit to patients of metastatic colorectal cancer if the primary tumor originates on right side. So panel believes that right-sided tumor, you should use cetuximab or you should use bevacizumab. However, the stalwarts in colorectal cancer says that patients with right-side colon cancer shouldn't be treated with cetuximab, and the left side can go either way. And this was Excel Growthy, which says that Folfox plus bevacizumab undisputedly is the most common first-line therapy in colorectal cancer, regardless of the sideness and regardless of the RAF and BAF mutation. So this is which was presented his paper in 2019 in ESMO conference. So we, apart from this RAS, KRAS, NRAS, and BRAF, we have two other things, which is microsatellite instability and HER2. Quick answer from Dr. Bharat Bhosle. You do it upfront or you do it later on?
Yeah, again, we have already answered this. We do all the upfront. As you said, no, we started discussion because we know that now
yes.
therapy is also approved in the
yeah. So there is a meaning, there is a sense to do it upfront in another way, that those patients who are microsatellite high, patient with microsatellite high colorectal tumor benefit more from bevacizumab than from cetuximab. This was again a JCO paper 2019 with bevacizumab. They have a median survival of 30 months as compared to cetuximab and other arms. Again, Dr. Ghanshyam, do you get HER2 positivity in colorectal cancer? So what is your status? How do you treat them differently when you have HER2 overexpressed colorectal cancer? Dr. Biswas.
First of all, for a metastatic colorectal cancer, besides the RAS, we need to do BRAF, MSI, and HER2/neu in the sense that if any one of these is positive, BRAF, HER2/neu, or MSI, so this positive means, though if they are candidates for an anti-EGFR, but they won't respond. So that has been shown with BRAF also and HER2/neu also on MSI. So we
Yes.
have done around in a metastatic colorectal cancer around 45-50 patients of HER2/neu. So I am yet to see a HER2 positivity or overexpression in a case of metastatic colorectal cancer.
Yeah, so I have a couple of patients who are HER2 positive, although we have done everything for them, all the kind of therapies. But there was a paper in ASCO meeting abstract 2016. They says that as a second line therapy with an EGFR inhibitor, the PFS was significantly shorter in those with HER2 amplified tumor compared to those HER2. So this is an indirect saying that those patients who have an HER2 amplification, they may
Don't use it.
cetuximab or panitumab, and so this can be a predictive marker HER2 amplification as a predictive marker to anti-EGFR therapy. And so there comes my graph which says that it was 70-30, and now with HER2 positivity coming to 5 to 10%. So my 80-20 principle is confirmed, and in 80% of the time, my patient will require bevacizumab or benefit from bevacizumab upfront, irrespective of the sidedness. So here comes that 80-20 principle. However, it may get more complex if we use next generation sequencing, if we use liquid biopsy or Guardant 360 in our colorectal cancer patients who have widespread metastasis. So pole amplification, MET amplification, and other targetable genes and actionable mutation can complex this picture. But more or less, it can be said that 80% of the time, bevacizumab usage is right. So I think Dr. Govind Babu, we are short of minutes. I will finish that. So second, when we have to choose second line therapy, so there is a again data coming on the liquid biopsy. So please, so to check this RAS mutant status, that they are retaining the RAS mutant status or they are retaining their wild type. So on second line therapy, as we do in lung cancer, so there is plenty of data which says that please check their RAS status to define which bevacizumab or cetuximab panitumab to be given. I would just like to come to a last point which we were discussing about the ETS and depthness of response. So this was an ATOM trial. It was a randomized phase 2 trial. So initially I was of the notion that even if the patient is right-sided and resectable, I was tempted toward use of cetuximab so that I can have a ETS as it was shown in Coin or Fire study, early tumor shrinkage and depthness of response. But this was the paper which says that ATOM trial. So what they did, ATOM study was the first randomized trial comparing BEV and cetuximab for initial unresectable colorectal river metastasis. It was 1:1 randomization, and when they were assessed as a conversion therapy, so 1% for BEV and 49.2 for cetuximab, which was statistically not significant. So this paper concluded and published in British Journal of Cancer that both biologics, whether you use cetuximab or whether you use bevacizumab for this borderline resectable, both biological have similar efficacy regarding liver resection and acceptable safety profile. So that ETS and DOR criteria of cetuximab in the COIN study is actually negated by this paper, and they say that you can use both of them, either BEV or cetuximab, when you have to resect these tumors. So again, I would like to conclude that EGFR targeting has a key point whenever we have.
Yeah, can I make a comment, Ganesh?
Sure, please.
Very quick one. Sorry, I've been kind of in and out.
No, please go ahead.
So I understand that at most medical oncologists and with a lot of these studies, you tend to believe that there's not too much difference. But when we look at major liver resections, we've definitely found a lot of bevacizumab having been given along with FOLFOX. We definitely do have challenges in terms of the extent of liver resection that is possible. There are issues in terms of bleeding. So we cannot wish away the issues that we still face with bevacizumab, especially with very major liver resections.
Yeah, so absolutely right, Dr. Ganesh. We have to look at this patient. So we as a medical oncologist doing MDTs with colorectal cancer cancer. So we actually evaluate after 4 to 5 cycles or 4 to 6 cycles. We do not go beyond it. And usually patients get 2 to 3 bevacizumab, then we have to stop so that a major surgery can be done. So I think we are overshooting our time. It's already 6:31, and we gave a right message that bevacizumab, if used properly in a setting, in a personalized setting, can give a similar advantage like cetuximab. But however, as Dr. Ghanshyamba, this was insisted, we have to use this molecule judiciously for best of our patient survival. Thank you, and over to Dr. Govind Babu.
Thank you, Ankur. I think we've discussed almost every aspect that was required, and Dr. Ganesh joined us towards the end. I think it's very, very important that we discuss upfront for these patients in a multidisciplinary. Also has a look at this patient upfront. Then we can actually tailor our treatment better for our patients. Thanks, Ankur. With that, now I'll call upon Dr. Bharat Bhosle. I think he also doesn't need any introduction, and he's going to talk to us about UFT in colorectal cancer. Again, a case-based discussion. Yes, Bharat, all yours.
Am I audible now? Hello.
Yes, sir.
you are audible.
Yes.
Bharat,
Yes.
you can sing and we can understand that he is Bharat Bhosle.
Let me. You can see my slides also, right?
Yes. Go to full screen, that's all.
Yeah, just put it on first.
I'm going to do it. I have to do this. Okay. Thank you. Sorry. Yeah. So basically, almost most of the publications have been discussed nicely by Advait and Ankur. So nothing to talk about trials. So many trials. So we'll see, what we are doing in real life. So I have chosen 3 of my cases, rare scenarios, where we have discussed in metastatic colorectal cancer. Definitely, we have a role of maintenance, and that is why we are. And another thing is the biosimilars. The biosimilars had made it very easy because we can offer them now as a maintenance. So that is the beauty of bevacizumab biosimilar, and we see it is translated into the survival. So I'm talking about utility of UFT, that is tegafor-uracil, Lupora, that is the only available alternative to capecitabine 5FU in India. And I would like to proceed with my cases. How to jump to the next slide? Yeah. Hello.
Click on the screen and then use your.
Yeah. But sorry. I'm not used to it. Nowadays, everybody someone else is controlling your site. That is how So this is a 56-year-old gentleman from the Jaipur. So this gentleman, why I remember, because I am not actually administering him treatment, but every decision he takes from me and then go back to Jaipur and gets the treatment done. It's been last 5 years he's alive, and today also I have done a telephonic consultation with him. Interesting story. So here all the comorbidities: hyperthyroid, neomercazole, diabetes, hypertension. And he presented with some emergency with partial obstruction. He had a left iliac fossa pain, and the CT suggestive of there was a big cecum and ileocecal mass with multiple liver metastases in both lobes of liver. So Dr. Ganesh can contribute here in this particular case. So this patient was reported to me by my GI oncosurgeon friend. The patient underwent emergency right hemicolectomy, and during the surgery only the surgeon decided, because he was no expert in high volume GI center, he decided to take out few of the metastases, not all. So he addressed one lobe, and this is the histopathology you can see. On follow-up, so we did the PET scan afterwards because it was not available at the baseline. It was the CT scan of the abdominal pelvis. So on the PET scan post-operatively, there was nothing in the lung. There was a doubtful nodule, which subsequent PET scan showed stable. And initial mutational analysis was KRAS mutated, and subsequently we also did BRAF, and with the availability of immunotherapy, we subjected for MSI and PDL1 that was not expressed. So this was his baseline report post surgery, and you can see the report of KRAS. So this patient we counseled, as he had a metastatic disease, for bevacizumab-based therapy, but at that point of time, patient refused for targeted therapy. So this is what importance of giving only chemotherapy. Yes, not necessarily every time, but yes, you have to counsel them for targeted therapy also. So with the 6 cycles, the patient responded nicely. because he had a lot of comorbidities. I decided to give 2 drugs, not 3 drugs. And subsequently, after 6 cycles, looking at the good response, the surgeon again decided to intervene and to do the metastatic. So, Dr. Ganesh, are you there? He's not there. Okay. So subsequently, we continued the chemo.
Ganesh is there. He's there on the.
Dr.
Yeah, I'm there, Bharat. Tell me.
Yeah. So the question I need to ask: when do you know if you have resected one lobe? So what is the ideal time to get the patient for curative resection? Because this patient did not have the lung metastasis.
Right.
Emergency, the right hemicolectomy done at the same time. The surgeon addressed the part of the liver.
Yeah, I got that. Yeah. So now in my opinion, if you're doing an emergency surgery, it's and if you're not able to clear out the entire liver, probably a little far-fetched to kind of do a few and leave it behind. That would be my opinion. So I would probably address the colon first and then give chemo and go ahead with the liver subsequently.
Got it.
Now, having said that, I think just the fact there is bilobar doesn't make it unresectable. What is most important is the distribution of lesions within the liver. So one of the rule of thumb that one can follow is that if you have 3 or more segments of the liver which are free of disease,
okay,
then you are in with a reasonably good chance that the patient is going to come up for surgery at some point if they respond well to chemo. So I think that can be a rough guide to identifying the ones who are likely or potentially resectable at some point in the future.
Yeah.
Of course, then the point would be whether they are superficial mets or deep ones, whether but eventually, if you have 3 segments which are free, there is a reasonably good chance that you're going to resect them at some point.
Right. So it is very important point for the students who are attending. So we always discuss and Dr. Ganesh had made it very easy. This is the rule of thumb one should remember. So this case,
Bharat, one sec. Dr. Ganesh, do you have any other way of functionally assessing the liver? Not just saying 3 segments. Do you have any such assessment that you would like to tell us?
A very, very good quality CT is or an MR. Would be a good way of identifying and having a mapping of the lesions.
Right.
Now we need to do a CT volumetry before we go ahead with resection. So unfortunately, MR doesn't give the volumetric assessment. So that way, CT is much better. A lot of software is available for CT.
Right.
So we normally go by the CT volumetry, and that gives us a good assessment of the remnant liver volume. So if with a lot of chemotherapy, we are targeting a remnant liver volume of around 40%. If less chemotherapy is given, you can get away, and otherwise non-cirrhotic, no significant cash, that is chemo-associated steatohepatitis, then you can get away with even a residual volume of 25 to 30%.
Okay. So the paper where they were using a iron compound with MRI to assess the functional liver much better, but this is still very early stages. So
there is a lot of work being done on MRI with a lot of compounds, and functional MRI now is probably in the next decade or so. Functional MRIs may become big because finally you're only assessing volume and we're not quantifying function.
Yeah, that's right. So with so much of advances that we have in therapies today, I think this aspect is sort of little neglected. But I think that will slowly catch up, and I'm sure we'll be able to help many more patients once all this gets integrated together.
Right.
Yeah,
Bharat, go ahead.
So after the second metastatic the patient, we finished obviously the Folfox. For the student, it is very important if you have resected the entire metastatic sites and there is no residual disease. There is no role of adding any of the targeted agents to the chemotherapy backbone. So we gave Folfox, which is the ideal standard when you don't have any disease. Subsequently, we followed the patients with CEA, and in the February 2017, even the scan was in complete remission. There was no metabolic activity. In April, middle of the April, this 2017. It's not.
Bharat, can I just stop you for a minute? I think the point that you made about not continuing targeted therapy, I think is very, very, very important. Yes. Because people will assume that it was metastatic disease and continue.
Right.
So In fact, we've had debates about this quite a few times. So I don't think there is any role. I think that's the point that you very well made out.
So,
Yeah, Bharat.
so basically in April 2017, this is not 2020. I don't want to mention 2020 in the future. Sorry again. So patients started showing CA rising. So immediately that is the protocol. We follow the patients with, even in the adjuvant setting, we follow the patient with CA. And if the CA is rising, we go for further investigations, including whatever, if colonoscopy or CT. So CT scan was done and there was a solitary lesion again in the liver. CT thorax also done, there was nothing. There was a small nodule which was stable. So here it was a disease-free interval of 3 to 4 months. So completing the therapy. Sorry, what is happening? Okay.
Yeah.
So we again discussed. There was a small lesion. We and the surgeon sat together, and in May we did the RFA. So that is what important of using the alternative curative agents, and the guidelines very well mentioned. Even in the limited lung metastatic site, if it is ablated, can be ablated by any alternative measures. You should go for an aggressive therapy.
Absolutely.
Then after this, in June, the PET scan was in CR. Now I have a patient with metastatic disease, given all the whatever best possible efforts, and we didn't give anything, and there was a disease-free interval of 3 and 4 months. That made me think that I should give something, so that I should achieve a more time, because we know that in the second line the disease-free interval is going to be shorter than that. So here it could have been 2 months or 1 month. So here what I thought, because the patient was not affording for targeted therapy and anyways there was no disease, I thought, and actually I started this patient on Luporal at that point of time in 2016. This patient, sorry, yeah. So this is the scan where we ablated, and then what you do? I would like to come to Advait. If this is your case, then how do you go about just observing because there is no disease after the RFA, or you offer something?
I think this patient definitely has an aggressive disease, that you have done everything possible, including maximum rival resection, and then within 4 months, if there is a disease which has recurred, it obviously indicates that we are dealing with a bad biology of the disease. And he does have a RAS wild type, his BRAF, RAS mutant, BRAF wild type disease. And I would keep him on some maintenance with with a fluoropyrimidine group of drugs, whether capecitabine, whether 5-FU-leucovorin, or whether Luperal. I think it would depend on the patient characters and also what kind of toxicity one would want to avoid.
Yes.
I am very comfortable using Luperal in such situations because it doesn't have the toxicity of capecitabine like hand-foot syndrome, and it's much better tolerated. And I've had patients with such situations going on for 1.5 years with single agent Luperal as a maintenance treatment. Although there may not be too many clinical guidelines, or there may not be clinical trials to back this up, but this is what the practical experience is. Many of us actually do this.
Sir, Govind Babu sir, your experience?
Yeah, I think this is a good point. In fact, I have one patient who has finished 4 years of Tegafar. And she was an elderly lady, so she did well, but there was some residual disease. After some time, because of the toxicity, we had to stop. So I put her on that, and she's tolerating very well. In fact, unfortunately, her husband passed away during this time. She's now, she's almost 75, 76 years, but she's tolerating very well. So this is one of the longest ones that I have had.
So good to know that this because toxicity is very minimal.
Exactly.
And there is a data that UFT has equivalent efficacy as compared to 5-FU or the capecitabine. So this can be offered because there is less toxicity.
Yeah, in fact, Advait and me were discussing before we started. We had a drug called Carcidox. That was also a good one, but they have stopped manufacturing. So this is a very good alternative that we have.
Yeah. So we should share this experience because this drug has never been used by masses.
Exactly. In fact, that is what we discussed also before you joined. I said all of us have some patient and we should collect all the data and look at real world experience.
Why not? That is a good idea.
Sure.
So real life, this patient actually who had a disease-free interval of 3 or 4 months.
Yeah.
So this patient continued with the normal CA for till the next year's January end, when the CA started rising. And we got a second PFS, a disease-free interval of 8 to 9 months in this patient, which was 3 to 4 months before without offering anything. So definitely some kind of maintenance, not necessarily targeted, definitely offers an advantage. So at the end of January, again the PET scan was done. You can see patient had lung metastasis. Liver was normal. Now it started. The story started in lung in 2018. So so will so that is what the importance, as sir also mentioned, Advait also mentioned, the toxicity, the maintenance agent, the ideal quality of the agent which we use for maintenance is the lower toxicity. We don't want to hamper the quality of life. Otherwise, that importance of maintenance loses.
That's right.
So coming to the next case, so I have chosen the real life cases. This is another patient of mine who was 65-year-old female. She had diabetes, hypertension under control, presented with PR plate, and the evaluation shows it as she has a malignancy of the colorectal with extensive liver metastasis. Now coming to Dr. Ganesh, the patient of we clearly know that even the medical oncologist can say this is not a patient for surgery. So this patient was like that, extensive metastasis. We could not see the liver, normal liver in the PET scan. The patient also sees that there is something problem with the liver. The entire liver is like like a light. So this is unresectable disease. So as we discussed initially, we don't go for anything, and I started immediately without thinking of KRAS wild type or mutated. I chose this thing, M-Folfox6 with bevacizumab. The bevacizumab added in the second cycle. We started with first for some reason because patient had partial obstruction. It was a rectal tumor. So Dada, coming to you, Gancha Dada, can you hear me? Hello.
Yeah, please.
Yeah. So when you come across such patients, if suppose this patient is wild type, both wild type, so how do you approach? Because you were mentioning about the responses you get with cetuximab. So this patient is rectum with wild type of both wild type BRAF and this thing. So do you consider cetuximab plus?
Yeah. So in this patient, so you need, besides the RAS, so BRAF and HER2/neu and the MSI, as I said. So if all are wild type and the HER2 is not overexpressed and MSI is stable, so I think this is a candidate for combination chemotherapy with a doublet and an anti-EGFR.
Okay, so that is also an option. Yes, I agree with you. So this patient we give, decided to give 6 cycles. We completed, and patient had excellent PR. The liver lesions into complete remission. So coming to Dr. Ganesh.
Yes, Bharat.
So suppose in the beginning, if I personally feel that this is an extensive disease because this was seen by a surgeon and he said, Bharat, it will not come for surgery anytime. But looking at the scan, there was excellent response in the liver. So metabolically, there was no disease. Right. So do you think such patients we should give an option of, because patient has primary in the rectum. Now there are different protocols coming up, short course RT. So suppose there is excellent response, what we should do? We should give a RT to the rectum and then continue systemic therapy, or we should enter a surgical approach also should be there.
So it's tricky. I believe this patient also had peritoneal disease.
Yeah. So she had one nodule, absolutely one nodule. The rest peritoneum was clear. So
right. So it is tricky in the sense that when you begin with extensive liver metastasis, as you mentioned, that every segment of the liver is completely studded with metastasis. In my opinion, irrespective of how the response goes, it is usually only a temporary phenomenon, and realistically speaking, we are never ever going to look at a curative situation for these patients. You can have a great response and that persists for some time, and then eventually you're going to have disease coming back. So I'm not so sure how much being aggressive with surgery in such patients really helps, because it's now, as far as addressing the primary is concerned, it depends on whether the patient is symptomatic in any way or no. Otherwise, I would probably, if the patient is not symptomatic from the primary point of view, and we have such extensive liver metastasis and some peritoneal disease, I would probably, just continue with chemo.
Okay. Thank you for this. Is very important because talking to a surgeon is always important.
I think Dr. Ganesh is an excellent surgeon, because my surgical prof used to say a good surgeon is one who knows when not to do surgery.
Yeah. So, sir, tell you one thing: when we come across difficult cases, because we work in different institute, I do send my patients to him to take his opinion.
Excellent.
So I must admit that. So basically, after that, no, we started giving the infusion, and patient developed some CCF. So we called our cardiologist and test, and the ejection fraction was 45%. So drop in ejection fraction was not the only contraindication to stop the 5FU. There are guidelines where you do re-challenge in the ICU setup. So in the subsequent cycle again there was a problem and it dropped to 40%. So we have taken all those precautions and we admitted in the ICU. So in such scenarios, Advait, I'm coming to you. So how common you face this scenario? 5FU, it is a big problem, but what is the percentage? I think it is not that common because 5FU is the most commonly used drug, and as Sir said, it is right from the beginning. It is that was the only chemotherapy which they had the option.
Yes. So, Bharat, 5FU cardiotoxicity when used in Folfox and when used in head and neck in a TPF, we've seen different toxicities happening. The cardiotoxicity is also different. And we've seen that most of the 5FU cardiotoxicity happens after 72 hours. So in patients who are on day 3 of 5FU during the TPF regimen, they are the ones who have higher incidence of 5FU cardiotoxicity as compared to someone who's receiving Folfox or Folfiri or infusional 5FU for 46 hours. The first thing which I would like to say is that it's not very uncommon, but we need to be vigilant. If you're vigilant, then you'll start picking it up. As a resident, we started picking it up, and the common thing to look at is to just check the pulse rate of the patient every time that you're going near it. And asymptomatic bradycardia is one of the first signs of 5FU cardiotoxicity. So if patient is actually having a pulse rate which was higher at the beginning, and now after 5FU has been started, if pulse rate is around 60 or less than that, I would be really careful in this patient, that this patient may be the ones, because this is because of the vasospastic mechanism by which this bradycardia occurs, because the AV conduction blockage happens at this level. So it's basically coronary vasospasm. So you stop the 5FU or use the orsiprenolene to push up the heart rate. Many of these patients can recover, but we've also lost patients once in a while to this, because if this happens at night and sisters have not seen or not recorded the pulse in a proper way, suddenly the patient may have a massive cardiac arrest.
Yes. Ghanshyam sir, would you like to share your experience 5FU toxicity, especially colon cancer? We will not talk about head and neck cancer.
No, because I'll put some words as Advait said about head and neck cancer, because we are running a head and neck cancer trial. So he's right that we see more often more damage in head and neck cancers usually, because we are running a trial where 5FU and platinum versus a 5FU platinum with a test drug in head and neck. So I had 5 deaths, 4 deaths out of 9 patients. So the protocol was amended by Dr. Raghunath Rao and we shifted to paclitaxel. So we don't see much toxicity in regards to colorectal cancer except the rhythm disturbances. And once in a while, probably you'll have somebody losing the patient, as Advait rightly said. So if somebody, your resident or sister has missed at night time, otherwise you stop the drug and you re-challenge. If you have the same episode second time, then probably you will omit 5FU in the subsequent cycles.
Yes. So coming to Govind Babu sir, so what is an alternative in such cases? Because we tried re-challenging the 5FU, then we cannot re-challenge. Again, capecitabine has the same problem. It is ultimately it's a 5FU oral congenital, and it also causes cardiac problems. And so, what are the options we should look for such cases? Alternatives to 5FU. Advait, you can take this question.
Yeah, so alternative to giving 5FU is one that you can look at other options like oral capecitabine or tegaforuracil. There are other safer preparations like S1 or TACH 102 which have been used. There is also use of single agent irinotecan, as many people have used that, and even EGFR inhibitors can be used in patients who are wild type RAS, along with single agent irinotecan as one treatment option of choice in such patients where the 5FU toxicity does develop. But oral capecitabine is quite safe, but even then the risk is less, but it's not zero. Luperal would be a good option. Tegaforuracil would be a good option there. S1, TACH 102, both are not available here. There are certain situations wherein TACH, I think TACH 102 is just recently going to be launched now, but we would have some option in the future.
Yeah, so we have other options like S1 task, but that is at this moment that is not available.
Yeah.
And UFT has a comparison with the 5FU and capecitabine, so the cardiotoxicity is comparatively less. Because no, there are certain animal data where basically tegafururacil is a combination of two drugs where uracil is a DPD inhibitor, and ultimately what happens, the 5FU is not degraded to the endpoints metabolites FBAL and F citrate. These are the cardiotoxic metabolites, and in the animal study it has been found that these are the reasons for the cardiotoxicity. So ultimately the cardiotoxicity is less as compared to 5FU and capecitabine. So coming to the last case, this is
Bharat, I just want to make a comment here about the 5FU toxicity. It is, like everybody said, it is an important thing that one must remember. But one thing I've come across is I think we also need to check who is manufactured this 5FU, because we have had this issue in the past. So I think that is one thing we need to keep in mind as well.
Yes.
So it may not be because of 5FU, but something else which is used in expient or whatever. So I think that is an important issue that we need to keep.
True. So first thing for the students, again, remember that not blindly blame the drug, because it has happened in the past. You have to go back, get the vial, what is administered, what was the substitute, even what was the solvent used for it, what was the weight for it. These are very, very important, not only for 5FU, each and every drug of oncology.
Every drug, absolutely.
So the nursing is the backbone of our. Sometimes our nurses are so good working with the drugs. They are better than us sometimes.
Absolutely, I agree. Totally agree with you.
So this patient, was elderly male, staying with the only wife, no kids, and presented with metastatic colorectal cancer. These are very important things when we decide the chemotherapeutic agent for such elderly couples who don't have a support at society level. So good performance status, controlled diabetes, started on doublet with the bevacizumab. After the first or second cycle, he started complaining, I don't want to continue on this, just because he was troubled with the diarrhea and hand-foot syndrome. Now, sometimes this hand-foot syndrome is so bad, the patient doesn't want to continue the treatment because there are discomfort as well as the social discomforts. And he had myelosuppression also. And that is why, that was the reason. So, DPD deficiency is an important topic. So, I'll come to Ghanshyamda. So, how do you face this problem of 5FU and capecitabine deficiency? Because I had a trouble with one or two patients. Bad diarrhea, bad myelosuppression, severe mucositis, bad hand-foot syndrome. All four manifestation in one patient.
Yeah, normally, Bharat, normally you are not doing it unless and until you really face it difficult to administer in one cycle or subsequent cycles. Then you go for the DPD testing and then you find out, then probably you need to alter. Otherwise, as a baseline, we are not doing like for anti-malarial, like we do a G6PD in our part.
So it is not routinely done at the screening, and the guidelines also, international guidelines also mentions that routine screening is not important, because this is a because problem. Sir.
It's less than 3%, so it is not advised to do for everybody upfront. But like Ghanshyam said, as and when you face a problem, then you do it.
Yes. Yeah. So screening is not advised, but you have to be vigilant to look for the toxicity point of view, and if the moment you get toxicity, you have. So managing toxicity will go. So this is the data of DPD evaluation in head and neck cancer patients. As Advait said, head and neck cancer has a more problem because there we give longer duration. And this is the data by Vijay Patil and Dr. Kumar Prakash team from Tata Memorial. They looked at all these 34 patients based on the toxicity. You can see the toxicity, severe mucositis, diarrhea, myelosuppression. They subjected 12 patients who had severe toxicity, grade 3-4 toxicity, and of that 12 patients, 11 were mutant. So, toxicity evaluation is very important to pick up this mutant population. And 11 out of, because it is highly selective, so that 11 out of 34 is a higher percentage, but in the general population, it is less than 2.5% or 5%. That is the, I think, that is the overall incidence among the general population. So here, in the head and neck cancer, they obviously, modified their treatment. But what happens in colon cancer? So this is a series published of 5 patients in which there was severe toxicity. Again, here you can see we demonstrate complete absence of severe toxicity in all patients and cycles analyzed. So in 5 patients, 22 cycles where 5FU after the toxicity stopped, and they used tegafururacil. So in 22 cycles, absolutely there was no toxicity. And you can see here In the first cycle, these patients had toxicity. They looked at the mutations. 4 out of 5 patients had heterozygous mutation, and you can see the initial patient received 5FU based chemotherapy, developed toxicity, and from cycle 1 to 5, they used UFT. Subsequently, the dose was increased, and 90% of dose of UFT was well tolerated without any toxicity. So this is what data and encouragement for us to use this alternative whenever we have such patients. So tegafururacil is a viable alternative, as we discussed, to oral capecitabine S1 or 5-FU-leucovorin. It has a comparable efficacy that is documented. It has compared with the 5-FU-leucovorin and capecitabine. Better safety profile, that is very important. Then it may be preferable in high risk patients who shows high risk toxicity like DPD, as we just saw in the previous slide. Elderly patients, as Sir Govind Babu sir mentioned, one of the patient is on tegafururacil for 4 years. That is fantastic data. And sometimes the patients with renal dysfunction. So if we look at the capecitabine, below certain level of GFR you cannot use capecitabine. So below 30. So these are the subset of patients you can try this. And again, we saw case of cardiotoxicity where definitely there is a scope to use it. And UFT further assumes more importance in particular today's era, where we try to shift the patients from IV chemotherapy to oral therapy. So today, again, because of COVID, I think this drug has come back to consideration. And we need more and more well-designed, maybe as Sir mentioned, we should have a collaborative group and we should collect our data, because we discuss in small meetings about personal experiences. We should put all that experience together to have a good data. And thank you, Lupin, for giving the opportunity to discuss these cases. Thank you. Over to Sir.
Thank you, Bharat. I think those were nice cases, and as you also mentioned, I think we should all collect all the cases that we have and publish it as a real world experience. So I think over to Lupin people.
Thank you so much. On behalf of UPIN, I thank each one of you, our program director and expert faculty, for today's session, for giving us time and for a wonderful discussion. Thank you so much. Have a great day ahead.
Yeah, Shika, I think again I would reiterate that you look at some sort of a mechanism to collect all this data of patients across India, and maybe we look at a publication.